Thank you guys for having me. I think Day at Lung Science started about 4 or 5 years ago, and I've been coming back and forth now since Malago was pre-construction, and it's just amazing every time I come back to see the work that MLI has done, as well as the entire campus has done towards promoting health. This is going to be a 2-part talk, so this is going to talk a little bit about what sort of got us to here where we are right now, and the next talk will be with Dr. Argento and Dr. Lee, who will be talking about what the future looks like in terms of our work with MLI and our partnership. And so, as Dr. Wardy said, I'm an assistant professor at Johns Hopkins. The title of this talk is The Global Burden of Obstructive Lung Disease and Management Strategies. I'm part of the Center for Global Health at Johns Hopkins, and the mission of our center is to provide high-quality research and training for a range of non-communicable diseases in low and middle-income settings. We work here in Uganda as well as in Peru, Nepal, India, Rwanda, and the goal is to standardize training and research across the sites to understand the risk factors as well as management strategies for a range of non-communicable disease. Disclosures are funded by the NIH, NHLBI, Fogarty, NIEHS, MRC, as well as the Else Corner Fresenius Foundation, and all of these foundations contributed to the input in this talk. And so the objectives of this talk is to characterize the prevalence and risk factors for chronic respiratory diseases across low and middle income settings, as well as stress strategies for the prevention, diagnosis, and management in these settings. Non-communicable diseases, chronic respiratory diseases in particular, account for the third leading cause of death, and 90% of morbidity and mortality occur in settings such as Uganda. And so, over the past decade, we've really started to understand the epidemiology of these various diseases. And so we're going to focus on 4 diseases: COPD, asthma, chronic bronchitis, and restrictive spirometry. And we have a range of observational studies which roll into field trials. And so we start off with the lung function in Nakaseke and Kampala study, the Ground South cohort, the Global Excellence in COPD Outcomes trial, which is just finishing, and a low-dose theophylline trial, which will be beginning. I'd like to start with this graph, and it's a variation of the classic Fletcher-Pieto graph. And so on the y-axis, we have FEV1. This is our main real pulmonary outputs, the amount of air we can get out in 1 second to spirometer. On the x-axis, we have a time. And so lung function begins actually intra-utero. This is something we don't really think about and understand. There's a range of risk factors that have been identified intra-utero. As you grow up to the age of about approximately 25, your lung function increases, after which your lung function declines. This is what sort of normal, healthy lungs would look like. This is what we call the lower limit of normal, so it's the 5th percentile. All these risk factors can result in a lung function attenuation up to the age of 25 or accelerated decline. And after a certain point, you sort of get below this lower 5th percentile or the lower limit of normal, and that's when you become symptomatic. And so, over the history and time, we find a number of evidence-based risk factors. So micronutrient deficiencies, vitamin A has been shown to decrease lung function at birth in Nepal. Malnutrition, smoking during pregnancy, potentially biomass fuel smoke, which is being studied now. Respiratory infections in childhood, poorly controlled asthma, and tobacco smoking. And finally, once we get into adulthood, and where we're going to be focusing about in this talk, tobacco smoking, biomass fuel smoke, occupational exposures, as well as comorbid conditions can all result in progressive lung injury. And so the first study where we really started to think about this was the LINK study. And so this was done with actually Bruce and Robert Kalyasubla in Nakaseke as well as here in Kampala. And the aim of this study was to understand the role of urbanization on the prevalence of COPD, asthma, chronic bronchitis, as well as restrictive spirometry. Determine the differences in risk factors for chronic respiratory disease between urban and rural populations, and then finally describe the burden of symptoms and functional status among those with chronic respiratory disease. And what we did was a population-based sample. And so fresh air was previously done in Masindi. Up here, we looked at Nakaseke as well as Kampala. There was a population-based cohort. We enumerated 25 areas in each of these sites, and we randomly sampled the population within, so 1,000 participants per site. We applied detailed demographic questionnaires in spirometry, and for the definition for COPD, we used the lower limit of normal. And we ended up recruiting about 1,502 participants with acceptable spirometry. The average age was 46.6, 47% were male, and 56% were rural dwellers. And one of the most interesting findings was to sort of show idea, just throw out numbers. How many people do you think, what percentage of the population had one of these respiratory diseases we were looking for? Jane? 30%. 1 in 5 people we sampled had a respiratory disease, either asthma, chronic bronchitis, restriction, or COPD. And when you extrapolate over that entire population in Uganda, that's actually a profound burden of disease. That 1 in 5 individuals, either in the urban area or the rural area, had one of these diseases. The reason why I put this graph is not, figure is not necessary for you all, but when I present this slide, one of the reviewers at Thorax said Nagasaki is not in a rural area. And so I had to go into GPS data and show the difference between Kampala and Nagasaki, because reviewers, when they're just looking at papers, really don't have an idea of what that looks like and what to understand in terms of risk factors. And so on the left panel, we have the crude estimates. On the right panel, we have the age-adjusted estimates. The y-axis is prevalence of disease, the x-axis is disease type. What we found was a significant difference between the urban, which is the darker area, and the rural population. We found a 6.1% age-adjusted prevalence of COPD in our rural areas compared to 1.5, 4.4 for asthma, and 9.7 in the urban areas. And so there's a significant distribution in terms of urbanization. And chronic bronchitis and restriction actually were similar across sites, though the rural area tended to have higher levels of chronic bronchitis and restriction. And so the beauty about being able to do population level work, and so not necessarily focusing on the clinic, but actually going out into the community and sampling the population, is this concept called population attributable fraction. And what population attributable fraction does is it takes our risk factor and it takes the prevalence of the risk factor, combines the two, and lets us estimate what is the actual contribution of that risk factor to the burden of disease. And the single most important risk factor in our setting is this, rural setting. 50.1% of people with COPD, that burden of COPD is attributable to rural setting. That's sort of lagged behind by tobacco daily smoking, which is about 19%, as well as tuberculosis, which, though more of an effect, is less prevalent in these settings. Similarly for asthma, urbanization was the single most important risk factor for asthma. Tuberculosis, though, sort of independent of population attributable fraction, is the single most important risk factor for lung function injury in our settings, right? And so this is forced expiratory volume in 1 second, this is forced vital capacity, and this is our ratio by which we use to diagnose the COPD. And tuberculosis is a strong signal for decline for both of these. And so what we now understand and what we think about is tuberculosis and post-tuberculosis lung injury. And that's actually an area that I believe you guys are focused on, right, Bruce? And it's an area where a lot of different populations are focused on, this idea of tuberculosis as an independent risk factor for COPD lung injury. So there were a couple limitations to this study. First of all, it was a single site. Second of all, there was a big thing that was missing, that was biomass. And the reason why biomass wasn't included in these analyses is there's 99% of individuals use biomass in Nagasaki, 92% of participants use biomass in Kampala. And so it was tough to differentiate. Furthermore, we were interested in looking at what this looked like across sites. And so the ability to use population-based data is we can concatenate that data with other population-based estimates. And so we combine data across sub-Saharan Africa, Asia, as well as South America to generate pooled estimates to understand these risk factors. We took 2 NHLBI studies, funded studies in Peru, Argentina, Chile, Uruguay, Bangladesh, 1 FIC funded study, which was ours in Uganda, as well as the Fresh Air study, which was Bruce and Rupert Jones and Fred Van Gemmer previously did at Masindi. And from that, we were able to generate about 12,396 participants who had acceptable, reproducible spirometry. The average age was 54.9 years. There's about an equal distribution of men and women, 48.5 were women, and 38% of these individuals were exposed to household air pollution. We standardized the reference of COPD across the population to the lower limit of normal using the GLI mixed reference value. And we were able to do a range of analyses. The first one I'm going to talk about is household air pollution and obstruction and spirometry. The second one, COPD and socioeconomic status, prevalence of asthma, COPD overlap, post-treatment pulmonary tuberculosis, and finally, malnutrition and TB. Across the cohorts, the prevalence was 8.8, and so these are each of our sites listed on the y-axis. The prevalence of COPD is dichotomized by gender, women on the left, men on the right, and then we stratified based off FEV1, looking at mild, moderate, and severe. And this graph is busy, but it's rich, right? And so these areas with high levels of COPD among male populations, MATLAB, DACA, where do you guys think that this is coming from? What's generating these high levels of COPD in these settings? Smoking, exactly right. And particularly, you can see the distribution among men and female, right? And then the smoking phenotype actually generates a much more severe phenotype of disease. In areas like rural Puno and Nakaseke, we find an equal distribution of COPD, and we don't find this severe phenotype. And so that got us thinking, biomass. And so every day, 3 billion people use biomass fuel for cooking. It's not a rare occurrence that we only have in Nakaseke. 90% of rural households in low and middle income settings use biomass daily for cooking and heating. And the range of exposures differ. So this is actually a picture from our site at Link. This is one of our sites in MATLAB, Dhaka, Bangladesh, and then finally Puno, Peru. And so the type of cooking, the type of fuel use, the type of exposure is unique and different. Across the entire population, and so here's the all sites, and these are individual site specifics, we found an overall increased risk of 1.41 using multivariable logistic regression for biomass fuel smoke and obstruction. This effect was more profound among women, so women exposed to household air pollution were 1.7 more likely to have COPD. And we found that these individuals exposed to COPD have greater severity and are more symptomatic. And so when looking at the granular data, individuals that reported daily biomass use actually were more symptomatic and had increased severity. While this was a cross-sectional study across sites, when we look at age sort of on the x-axis and the prevalence of disease on the y-axis, we see this unique split. And so this is red is in biomass and C is clean fuel. And so we see an increased prevalence of COPD by fuel type, and that actually differentiates over age. What about socioeconomic status? And so going back to this graph, thinking through what are the risk factors across the lifespan of an individual. Socioeconomic status melds uniquely with every single one of these: micronutrient deficiencies, malnutrition, smoking during pregnancy, biomass fuel, traffic, pneumonias, as well as subsequent injury and exposure across the lifespan. The big problem with socioeconomic status has always been the variables, right? And so you ask someone in Nakaseke, how much money do you make? And you get very variable responses, particularly among farmers. And so what you have to do is actually principal component analysis. And so we combine SES factors in the composite index. So we looked at household income, so that doesn't really sort of have an effect individually. Household size, which didn't have an individual effect. Secondary school, sort of. But combined, the SES composite index, the 25th percentile versus the 75th percentile, was about 1.23 increased odds of having COPD. And so household air pollution, low socioeconomic status. What does COPD look like in our settings? And so one of the big issues we run into, particularly in MLI in the clinic over here, is differentiating asthma and COPD. And so we have asthma, we have COPD, and we also have this phenotype called asthma-COPD overlap. And so one of the interesting things we can do with this sort of high granular data is actually stratifying the population. So we found that this population had about 13.6% prevalence of asthma, 4.8% were COPD only, and this is a substrat of the original. And among those with asthma-COPD overlap, individuals had 31% severe obstruction. So it's perhaps that this phenotype of asthma-COPD overlap is unique in our settings and different from what's reported, where these individuals in the United States and Europe that have asthma and COPD are not nearly as severe in terms of their level of obstruction. And this is all working towards an idea or hypothesis that the disease we call COPD in Uganda is distinctly different, and it's different across settings. The last analysis I'm going to quickly talk about, and this is one of my favorite graphs because it actually plots out every single one of our participants in the chart. And so on the y-axis we have z-scores, and so this is going to be basically, this is cutoff is what we look at for COPD, it's 1.86. And on the x-axis we have body mass index. And we wanted to see, was there a cutoff by which body mass index conferred an increased risk for COPD? And with multivariable logistic regression, we find that relationship about 19.8. And this is unique in you. No one's actually found a cutoff that's unique to this population. We use something called a BODE index, for prognosticating symptoms in COPD, and that cutoff in European populations around 21. Individuals who fell below this cutoff of about 19.8 were 2.28 times more likely than an individual above this cutoff to have COPD. And that this trend was actually consistent across our sites. And so we now know that the risk factors for COPD are different in our setting. We know that the phenotype and the presentation is different. And we know that there's different presentations of disease that confer specific risk. And so over the past decade, we've sort of identified risk factors, we've described the prevalence of disease, and it's left us in a position where we have a huge number of people that have been identified with disease, and we have limited understanding or capability for managing these individuals, especially when it appears that these individuals have unique presentations of disease. And most of the studies that we cite or we refer to have been done in high-income settings, where there's no biomass exposure, there's no neonatal malnutrition, there's no recurrent infections during childhood. And so I'm going to quickly present 3 intervention trials. And so these are all done in participation with MLI, and they're actually all done here in Uganda, which makes them even more meaningful. The first is the GECKO study, which looks at case finding for the identification of COPD, action plans for self-management of COPD, and then we'll talk about a trial that will be rolling out in the next year, which looks at maintenance pharmacotherapy for COPD. And so GECKO is a multi-site collaboration. Our major areas of recruitment are in Peru, Uganda, and Nepal. And the important thing is around this idea of socioeconomic status and health infrastructure. So we're interested in the GECKO study to figure out how you can implement case finding across a population-based setting and assess the effectiveness of self-management within unique and different health systems. And so we're looking at Peru. We're looking at an urban area called Lima. GDP in Peru at the time, about 3 years ago, was 6,661. Population of 30 million. You'll notice the populations are the same across, but what's unique and different is lifespan. That correlates very closely with GDP. Lifespan in Peru is 74.52. In Uganda, it's 58.65. GDP is about $571. This is per capita. And in Nepal, it goes up to 67.98 with a GDP of 694. So the first thing we wanted to do is look at case finding. So we wanted to see whether or not there was a diagnostic accuracy of case finding instruments with peak expiratory flow. And what this involved is recruiting 10,500 people across our 3 sites. We're recruiting 3,500 individuals per site. And this has actually been well documented in high-income settings. And so we take a set of questions. These are 5 questions. This is tough to see, but the first question relates to cough and mucus production. This relates to respiratory symptoms. This relates to dyspnea, smoking, and age. And it stratifies individuals between high risk and low risk with the aim of further obtaining spirometry if they're high risk. This is the original study. It's found in AUC, so sensitivity on the y-axis, one-line specificity on the x-axis, and you see this nice curve with an AUC of 0.72. The preliminary examination of our data found that there's pretty good correlation. So using just 5 items, we have a sensitivity of 95% and specificity of 50%. But that's not great, right? Usually for an AUC, you want to get a 0.8, 0.9 to actually implement it. A group out in New York actually found that adding peak expiratory flow to these case finding questionnaires can increase your AUC to 0.9. And so what we're doing is actually looking at these questionnaires, peak expiratory flow, and comparing it to spirometry across our settings. The second thing is what happens when we identify all these people, and that sort of gets us to where we are with these other studies now. What do we do with all these people that we identify with COPD? And one component around COPD for those that have managed COPD is around exacerbations. Exacerbations are a significant component of both morbidity and mortality for individuals with COPD. We wanted to test the clinical effectiveness of COPD action plans in the change in St. George's Respiratory Questionnaire, which is a sort of respiratory 30-item respiratory questionnaire. But furthermore, we wanted to actually assess the cost effectiveness. One of the big impetuses in terms of expanding as well as disseminating our research is ensuring that this is cost effective for the various countries we've looked at. And so after about 6 months of formative work, both here in Uganda as well as in Nepal and Peru, we developed action plans. And so action plans act sort of like a stoplight. Your basic baseline level where you're doing fine, you're at the green setting. This is the yellow setting. This is where you start feeling a little bit more sick. And so if you're having increased cough, if you're having increased phlegm, we actually have you do corticosteroids as well as antibiotics. These are all community health worker delivered. So in Uganda we have VHTs, and so these are delivered by community health workers in Nakaseke at the patient home. We do case finding, we do education, we do regular follow-up with the VHTs, making sure they're going back, and we're doing process evaluations to see the kind of education, the kind of care delivered. We'll be following up these individuals in the RCT. We'll almost complete the trial. There's about 100 per site, and we'll be finishing the trial probably in another month or two and assessing what the cost effectiveness looks like across the various settings that we're working in. So we talked a little bit about how to identify COPD in our settings. We talked about what to do with exacerbations. The big issue now is really around management, daily management for COPD. And so I'm going to talk a little bit about a low-dose theophylline trial that we're rolling out, but it's around a philosophy that we've been thinking about really for the past 5 or 6 years, and that's understanding COPD in our construct as a new endotype, or a novel phenotype. And so phenotype, endotype, phenotype is an expression of disease, endotype is actually a unique mechanism of injury. And based off of our work we're doing, there's pretty reasonable suspicion that the COPD we see in these settings, the COPD from biomass, the COPD from malnutrition, COPD post-tuberculosis, may be completely different from that from cigarette exposure, where 99% of participants have been enrolled in clinical trials. A lot of work's been done. Actually in Mexico, Rivera colleagues have looked at biomass-associated COPD. It's found an airway-predominant phenotype. There's increased cough, there's increased sputum production, and there's increased airway reactivity. We actually found this in our cohort study, right? So individuals who were under the age of 30 had an increased odds of having bronchoreactivity. Once you get to 50 and beyond, you lose that. And so, our hypothesis is that biomass and all these various exposures may result in increased inflammation, increased airway reactivity, and at some point in time, there's a fibrotic stage. There's a stage where that becomes actually an obstructive lung phenomenon, a fixed obstruction. There's increased hyperresponsiveness. Airflow obstruction is less severe than in smokers, but these individuals with biomass COPD have lower quality of life and tend to be more hypoxemic. And going back to original graph, this is probably what tobacco smoke looks like. This is probably a representation of biomass-associated COPD. Phenotypically, that's how patients present. How does it look histologically? So CS represents cigarette smoke, BS represents biomass smoke. There's increased goblet cell hyperplasia in individuals with cigarette smoke, but in individuals with biomass smoke, we find increased fibrosis around the small airways. Furthermore, there's increased acanthosis, which is basically this pigment deposition, and finally, increased intimal median thickness in the pulmonary vasculature. Despite all this, if you actually look and try to figure out recommendations for low and income settings for therapy, you find an article from 2001, which isn't that different from what we use in our settings. It starts off with inhaled salbutamol, it adds on epitrophin bromide and salbutamol on top of your short-acting bronchodilator, and then finally steps up potentially to low-dose theophylline as well as inhaled corticosteroids. Yet, a lot of people have looked at the availability and affordability of these medications in the settings that we work in, and it is neither available nor affordable. WHO Health Action Network looked at actually the pricing and availability, and so they looked at this drug in India, and it actually costs about 1.6 to 2.3 per day's wage for the average government worker. And so the problem is when you standardize the average government worker, 80% of the Indian population makes less than that threshold. They didn't look in specific countries in sub-Saharan Africa, but that estimate goes up to 4 to 5 days of the average government worker in these settings. So these medications are largely not affordable. The other big issue is they're not available. So we have actually a census of all the pharmacies in Nakaseke, and not a single one has ipitropyl bromide, which is sort of our second level of recommendation. The third issue is around this entire idea of inhalers. And so taking inhalers is A, a complex medical task. B, in a number of our settings, such as Peru, people don't want to take inhalers. They don't believe it helps them, and that sensation of inhalers coming into their lung, they believe actually causes their disease to worsen. And so the issue of inhaler-delivered medication is a huge issue here. And so one of the things we wanted to look at is low-dose theophylline. So low-dose theophylline has been well studied in patients with asthma, and low-dose theophylline as monotherapy actually works very well. It's been around for 120 years. In 1888 was when it was first discovered. And there's well-known mechanisms that it relaxes smooth muscle, so it causes bronchodilation. The mechanism of action is cyclic AMP, cyclic GMP, and there's increasing bronchodilatory response over 10 milligrams per liter. But theophylline also has another mechanism, and it's an anti-inflammatory mechanism. And if our hypothesis is that biomass-associated COPD is an inflammatory process that results in distal end airway fixed obstruction, perhaps it can mediate that. And so it results in decrease in IL-10 and inhibition of NF-kappa B. But more importantly, what it does is actually works through something called histone deacetylase. And so this is a glucocorticoid receptor. It's the thing that really functions whenever you give a patient inhaled corticosteroids. And glucocorticoid receptors actually go into the nucleus and decrease transcription of inflammatory genes. That is actually modulated by this histone deacetylase, and that's a mechanism of action for theophylline. And so our hypothesis is that low-dose theophylline will result in decreased airway inflammation, improves bronchodilatory response, and can serve as both a cost-effective and, most importantly, clinically effective daily dose. And so we're conducting a pilot randomized controlled trial. We're looking at an intervention group, which is low-dose theophylline versus a placebo control group. The primary outcome is to define the health impact of biomass COPD across Uganda, across Kampala and Nakaseke, and then test the efficacy of low-dose theophylline among adults with biomass COPD in Nakaseke. We're actually going to generate Markov models, and so if you take lung function over time, and so we're going to follow these individuals over a period of a year, and we're going to actually standardize it to our known population estimates, you can model lung function over time, and sort of individual sort of starts off with mild obstruction, goes from moderate obstruction, severe obstruction, very severe, deceased, and then that sort of model can go from point A to point B. And you can cost and evaluate the incremental cost effectiveness of this therapy over the lifespan of an individual based on this one-year trial. As part of the trial, we'll be doing detailed measurements, and so we'll be looking at air pollution, we'll be following SGRQ, which is our primary outcome, as well as a range of socio-demographic variables and risk factors which we've previously identified. And with the aim of this, combined with the GECKO trial, as well as a number of other trials that are going on globally, we can create a package of interventions that work for our disease type here, as well as our health systems and settings. And so that was fast, but I wanted to also make sure we have time to talk about the next set of things, next areas of focus of research and work we're going to be doing. But in conclusion, global burden of chronic respiratory disease is high. It's a result of unique exposures to settings, and understanding these exposures and understanding health systems is paramount to developing context-specific management strategies. Finally, I believe, and I really do believe this, we can expand treatment to our settings. I think MLI is an example of that, right? I don't think anyone would have thought, I thought Bruce was crazy when he told me he was going to build a sleep lab and a bronchoscopy suite, and and every time I come back, Bruce is talking about more and more stuff, and it's happening, right? And so we can deliver very high quality care. As has been done by William and the group before. I was a trainee when I came first 7 years ago, and we were doing bronchoscopies in Malaga, and so we can continue to build and we can deliver the highest quality care, and also generate evidence which not only helps our population, but really informs the global burden of disease estimates as well as global management strategies, which is our goal. Really turn our MLI into a center of excellence. So a lot of people sort of think globally that have worked on this project and I've interacted with, and certainly there's a lot more people at MLI that have contributed to this research and science, and I'll sort of stop there for questions. As yet, and so a lot of us are thinking about more broad interventions.
Thank you very much, Trishul, for presenting very good data. What are those guys like in Peru, Bangladesh trying to do? So what can we learn from them in terms of, what can I say?
Best practices?
Yeah, best practices.
Yeah, I mean, the crazy thing is everyone's doing the same thing, right? Because we're dealing with 2001 guidelines and there's been no evidence generated since. And the beautiful part about it is we're part of a majority of trials, frankly, that are looking at what we can do. So the data that we're generating here is actually going to be utilized in international guidelines. I think that the interesting thing is the management style. So Peru has a pulmonologist for most patients, right? And so whereas the majority of pulmonologists reside here in Kampala, we have a couple in Mbarara, they actually do see pulmonologists on a regular basis. What those pulmonologists say to us, though, is that this disease is very different from tobacco-related disease, and they've noticed a distinct difference in phenotypes. And so I think they're as equally frustrated as we are in terms of management and what's working and what's not working for their patients. I think we really know what works for individuals with tobacco. Right, and then there's also great mitigation strategies. So the framework for tobacco prevention, the framework for control for tobacco is really something that can be implemented to reduce the increased risk. But there is this underlying socioeconomic status issue, biomass issue that we're just not going to be able to fix. And understanding what sort of affects that disease phenotype is important. But I mean, yeah, and so in Peru, most patients are going to be able to see a pulmonologist. The issue is they're sort of limited or have their hands tied in terms of what kind of therapies they can deliver.
Thank you, sir. My question is, in post-TB COPD, is there any law after the treatment of TB to have presumptive treatments after a given period of time, like a year to stop?
I don't think so. Once again, I'm not a TB expert, and so there's a question about whether or not you can give additional treatments thereafter. I mean, certainly there's treatment failure, and you always want to make sure that you're treating appropriately, but there's appropriate diagnostics in country now to make sure that the right medications are being delivered. But I don't think that there's actually, at least I don't know of any data that suggests prolonged courses.
Thank you very much. I'm just wondering if you found any data that's specific to COPD in children, and if the management options remain the same as the ones you projected.
COPD in children is very, very unique and rare, right? So, almost every phenotype of COPD we think about actually really occurs in adult lifetime, and that's because of this little graph right here. Hold on. So yeah, in order to get to the lower limit of normal, you really have to sort of get to a certain age period where you're down. The COPD in children is something that was sometimes a result of bronchopulmonary dysplasia, which actually is very common here. And what happens is, if you're born very premature, you don't actually get to this area at all. And so you might have fixed obstruction. The other reason why COPD is not necessarily diagnosed in children is it's tough to get them to do spirometry, right? So you may be talking about oscillometry as sort of the diagnostic technique among children. We know very little about what that fixed obstruction in children looks like because frankly there's just such a small population that experiences that. And it's very rare in children, and more so you'll see that in adolescents and early adulthood in their 20s. And so I had a 21-year-old guy from Puerto Rico that actually had bronchopulmonary dysplasia. You can also see it frequently post-TB related disease if there's extensive fibrotic changes and obstruction.
About the drugs, we've struggled sometimes with the ministry, sometimes we're called to participate in writing guidelines, but I've tried to discourage the use of aminophylline, in particular in asthma, but somehow it seems to be coming back. Is it a good thing or a bad thing?
So good thing and bad things relative, right? So full dose theophylline is a bit of an issue. You have to do monitoring of theophylline. There's risk factors for theophylline. They include seizures, they include arrhythmias, they frequently result in GI effects. Low dose theophylline, so 250 milligrams extended release, doesn't require clinical monitoring. There was a trial called the LODO trial that was done by the Asthma Networks trial, and I can send that to you. It looked at low-dose theophylline, it looked at montelukast, it looked at combination low-dose theophylline, montelukast, and ICS. And what they found is individuals that were just treated with low-dose theophylline alone actually had significant control of ACT. Granted, combination combination short-acting bronchodilators, long-acting bronchodilation is the gold standard because it does work and it does improve treatment, but it's impossible to find that, and then also the cost of patients is exorbitant. And so, if you tell an average patient out in the village to take this inhaler once a day, that's going to be their entire salary. We can't even find that right now in Nakaseke, and so, it is the gold standard, but at the same time, that gold standard has to be accessible and affordable to people. And so, until we can get to a point, the other thing I did talk about, but I mentioned is that these inhalers are one of the most complicated medical devices created because they have to give the exact same dose despite how many times you deliver the dose. So, if you think of propane tank, when you get to the end of the propane tank, that flow is going to be far less. That can't be the case with inhalers. And so until we reinvent the technology of inhalers or even consider nebulizers, it's going to be largely inaccessible. And there's a reason for that, right? Because these companies want to make money. And so these products have been largely not generic for the past 20 years.
Is there a role for doing follow-up despite or lung function test for post-TB?
Absolutely. Yeah, absolutely.
Or finishing the treatment, trying to come after
There's two parts to that question. So the first question is whether or not to do spirometry post-TB. You should absolutely be doing spirometry post-tuberculosis. You should probably be doing it a year out. If there's progressive respiratory symptoms, you can do another set of spirometric values just to make sure that there's not an additional effect or additional process going on. In regards to annual spirometry, there's not great evidence for that. Right? So following people longitudinally for spirometry, you're not going to be able to sort of do much, but there is enormous value in understanding what lung function looks like after a hit like tuberculosis.
Most of the time we have been seeing patients who are really having very bad lung.
Correct.
Post-TB, and if there's a way of following them up, it's easier.
I think the problem with that as a diagnostician is what you frequently see is someone like the guy on the board right now. He had TB 20 years ago, and we have no idea what happened in between. And you're just getting a snapshot of someone who has severe obstruction, end-stage lung disease. And I think what you can take away from the slide is understanding how we can prevent us from getting there, how we can intervene in the immediate time, doing lung function estimates in the process is worthwhile. I'm going to actually give over the stage to Dr. Denda and Dr. Lee just because they also have